Welcome back to Medical Associates Health Check. I am Dr. Laisha Selvaraja. I am the clinical administrator for Medical Associates Hospital, as well as the head of accident and emergency. Today, we're going to talk about pancreatic cancer. It's something that is more common than you think, and we thought it'd be important to touch on it. With me, I have Dr. Yadish Singh, who's back again. Thank you very much to talk about this very interesting topic.
Yeah, it's wonderful being here again and to
Thank
talk
you.
about cancer that is very common in Trinidad and Tobago.
And it's surprising because in the past, people have not really thought about pancreatic cancer, but I think the incidence of it, like many cancers, is increasing.
Yeah, I think I agree that the incidence is increasing.
Because there have been a good number of celebrities that have suffered and lost their battle to pancreatic cancer. So one of the most well-known persons is Steve Jobs.
Yeah, so everyone who has an iPhone, the CEO, Steve Jobs, he actually was diagnosed, but with the endocrine pancreatic cancer. Some other famous people, Patrick Swayze
Yeah, I
from
know him.
Ghost, all right? He lost his battle to pancreatic cancer. The Queen of Soul,
Aretha Franklin.
Aretha Franklin.
Yes. So a good fair few people have suffered with this.
Yeah, and
this
these
disease.
are people who has the best of resources in the world. So unfortunately, because the cancer only presents very late,
Yeah.
treatment is very limited, and therefore survival is very limited.
So let's start with talking about what the pancreas is, because I guess that would be a great way to start the process.
Sure. So with me here today, I have a model of the pancreas.
Right.
And the pancreas is an organ that is actually located in the abdomen, but it's at the back of the abdomen. And the pancreas is actually very intertwined with your intestine and your spleen, and it's divided into different parts of the head, neck, body, and tail. Now, access to the pancreas is very, very difficult, and that's why it's very well hidden away in the abdomen, and it's very, very difficult to access.
When you say it's hidden, right, it's because there are other things in front of it. So actually the pancreas is located towards the back of the body. If you open up the abdomen, you'll see the stomach, you'll see the large intestine and small intestine covering the pancreas.
Yeah, so you have to move away the stomach, the small intestine, the large intestine before you can see the pancreas.
Yeah.
It's actually hidden at the back of all these things.
Right. So tell us about pancreatic cancer. Well, actually, before we go there are two different functions for the pancreas,
Yeah,
right?
so the pancreas actually has two different types of cells within it. There's cells that helps to regulate your blood sugar, and they produce hormones. It's called the endocrine pancreas, and they produce hormones such as insulin and glucagon. Now, there are also cells in the pancreas that helps with digestion, and that's the exocrine pancreas, and that helps us to digest all our foods, such as fatty meals, proteins, stuff.
Right. So now moving forward, you can actually say there are two types of cancers then. You have the ones in the exocrine system and ones in the endocrine system.
Yes.
Right. So let's break those down.
Yeah. So the most common cancer that is you will hear about and you'll know about, it's the exocrine pancreas, and that's the adenocarcinomas.
Yep.
And when people talk about, you hear that someone has pancreatic cancer, that's the one, and it's probably the most deadly type of cancer, and it's present in about 95% of pancreatic cases.
Okay, wow. And then you've got the insulin tumors and these sorts of things that are the endocrine type.
Yeah, so the
tumors.
endocrine have different types of cells. So they produce insulin. So you get insulinomas, the ones that produce glucagonomas, and they help to regulate the normal cells will help regulate your sugar,
Right.
your glucose. However, when these cells become tumors, they produce an excess of the hormones, and those become a problem.
Okay, so how common do we see pancreatic cancer in this population here?
So in Trinidad and Tobago, pancreatic cancer, it's the ninth leading cause of cancer in Trinidad and Tobago
For both men and women.
for both men and women.
Is there a higher incidence in one?
It's slightly higher
percentage.
in men, slightly higher in men. And in terms of mortality, it's the sixth leading cause of mortality in Trinidad and Tobago. Now, if you look at 2025 US statistics, they're expecting to see approximately 67,000 cases, new pancreatic adenocarcinoma cases. However, they also expect about 51,000 patients to die of pancreatic cancer.
So it's got a high mortality rate, which we want to touch on. I wanted to point out that alcohol and chronic pancreatitis are big risk factors for pancreatic cancer, are they not?
Yeah, so chronic pancreatitis is one of the known risk factors for pancreatic adenocarcinoma,
Right.
especially pancreatic cancer of the head of the pancreas.
Head of the pancreas, yeah.
Yes.
So what could we do to reduce the risk other than smoking, stopping alcohol consumption and smoking cessation? How can we reduce the risk of the chronic pancreatitis?
Well, chronic pancreatitis, I mean, you have to remove the inciting agent.
Okay.
And if the inciting agent is alcohol, then it has to be removed. So unfortunately, you'll have to stop.
But some people get pancreatitis from gallstones, right?
Sure. So gallstone pancreatitis, if it's associated with gallstones, then you remove your gallbladder, remove that source.
And a lot of the times the reason why you cannot the mortality rate is so high is because it's picked up quite late. It's an aggressive cancer that's often picked up quite late in the progression of the disease. And most of the time that's because they don't really see the signs or the symptoms come up early.
Yeah. So that's one of the problems of pancreatic cancer. Now, the 5-year survival of pancreatic adenocarcinoma, it's about 8%.
Oh, that's low.
And that has been like that for probably over the last 20 years.
So there's no advances in medicine that's been able to change that?
There has been advances in medicine. However, the survival hasn't really changed. There have been advances in treatment in terms of surgery, in terms of oncological treatment, and there are new treatments on the horizon. However, it's not they're still in clinical trials.
Okay. We'll touch on that as we go along. Let's start off with the signs and the symptoms.
The pancreatic adenocarcinoma, the pancreas of the head of the pancreas, it comes like a thief in the night.
Okay.
When it's detected, it's too late.
Okay.
Okay, so the common symptoms that you will get will be yellow eyes, or what we call jaundice.
Yeah.
All right. Weight loss. Patients have a loss of appetite. And this is often painless.
Yeah.
Now, in terms of, from our point of view, they may have dark urine and also pale stools. And also patients might have itching because of the jaundice.
So it's important to point out that it's painless because people can get jaundice from other conditions such as like a gallstone that we talked about it before, where it gets trapped and that's painful. But when you're getting yellowing of the eyes and there's no real reason behind it, I think we really need to start thinking about whether or not this is pancreatic cancer.
Yeah, so normally if you have yellowing of the eyes in a person who is above the age of 50 years old, that's alarming.
Okay.
And it must be investigated.
And then like you touched on the dark urine, the pale stool. But these are quite late symptoms. They're not something that comes up quite early.
Yeah.
But then you've got other tumors, maybe let's say in the body of the pancreas and then the tail. What are their symptoms looking like?
Well, those are actually worse.
Okay.
Because what happens is that the tumors in the body and tail, they actually have very, very late symptoms. Mm-hmm. And when they're first detected, they're probably already stage 4 cancers.
So it's
the reason being is that they will present with pain and weight loss. The tumor actually grows to a very large size. And larger tumors, they tend to spread locally and metastatic.
Okay. So we will go on further in our next segment. We're going to take a little break. So when we come back from the break, we will be talking to you on the diagnosis and how to treat pancreatic cancer. Don't go anywhere. We'll be right back.
At Medical Associates Hospital, We offer minimally invasive laparoscopic cancer surgeries. This includes liver, gastric, colorectal, pancreatic, and gynecological surgeries. Let's fight cancer together. For further information, call us today, 462-2092. Medical Associates Hospital, #1 comprehensive and internationally accredited hospital in the Caribbean.
Welcome back. So we're talking about pancreatic cancer today. Now we're going to dive into the ways of diagnosing it and what we do for treatment. So top ways of diagnosing pancreatic cancer. So we do have tumor markers, right?
Yeah.
So let's talk about them, CEA and CA19-9.
Yeah. Now, I mean, diagnosis normally start with your sign, your
Yes,
obviously your signs and symptoms that we spoke about
Yeah.
just before, which is your jaundice, your weight loss, your loss of appetite. Those we spoke of before. Now, you will examine the patient and look for signs of pancreatic tumors. However, we have tumor markers. Now, tumor markers are the CA19-9, which is pancreatic cancer specific,
Yes.
and the CA,
I think that's
which
very
is,
beautiful, right? Having a specific tumor marker.
yeah. However, the CA normally will also be elevated, but that's normally for colon cancer.
Cancer.
Now, these tumor markers, they're only elevated if the pancreatic cancer is producing them.
That's interesting. So if they don't produce them,
You
they
will
could be
get the
hidden away.
elevation.
So we also have the option of CT scans, and then we progress to MRIs.
Yeah, well, normally we start with an ultrasound,
Yeah.
all right? Because remember, patient comes with jaundice, you're not quite sure what you're dealing with. So normally your first radiological investigation would be an ultrasound of your liver and the biliary tree.
And right. So it's the liver and the biliary tree.
Yeah.
How well seen is the pancreas, given that it's a retroperitoneal organ?
Well, if there's a tumor, you'll pick up a tumor. So it might suggest there's a mass at the head of the pancreas. And also there may be dilated ducts because of the obstruction of the tumor.
Right.
If there's metastases or present a fluid within the tummy, we call ascites, from spread of the cancer, you will see that. So the gross things you will pick up. However, in terms of looking further into detection, you must do a CT scan or a CAT scan of the abdomen and pelvis, specifically a CT scan with a pancreatic protocol, which is specific for that tumor in the head of the pancreas. And why we do that, we'll be able to tell the size of the tumor and if it's invading any adjacent structures, such as the arteries and the veins.
Some patients have asked about a specific blood test. And in all fairness, some clinicians do use it, and that's CA19-9. They seem to think that's a screening test or a test that will determine the presence of pancreatic cancer. Why is there that common misconception, and how can we stop that?
Well, first of all, CA19-9, it's a tumor marker.
Correct.
For if you have pancreatic cancer. So it's actually not a screening tool. It has never been meant to be used as a screening tool. It has been meant to use as a surveillance tool. So a patient who has pancreatic cancer and is on treatment, whether it has been surgical or chemo or radiation or immunotherapy, we use the CA19-9 as a surveillance tool to see if there's good response or not.
Right.
Or if there's recurrence of the pancreatic cancer. So it has never been meant to be used as a screening tool.
I think the thing to point out, as you may have said before, is that not all tumors secrete CA19. Not all pancreatic tumors secrete CA19-19. So you'll miss CA19-9. So you'll miss the ones.
And also, CA19-9 is produced by other types of diseases.
Right.
So what happens is that if you have a mildly elevated CA19-9, this patient now has to be thoroughly investigated.
Right.
Which might mean invasive tests such as endoscopies, CT scans, MRIs, and maybe PET scans.
Yeah. And that's painful.
Which is painful and expensive.
Yeah. Okay, so let's say you have somebody that comes along with pancreatic cancer. What are you looking at in terms of treatment for them, and where do you draw the line for somebody that can have surgery and somebody that can't?
Right. So a lot of our cancers that we detect, because there isn't a reliable early detection system, we detect very locally advanced, or maybe what we call stage 4, which is very advanced. So those you wouldn't be able to, the very advanced, you want to go down to the palliative care treatment. However, if they are very early tumors or small tumors or locally advanced tumors, we may be able to treat them with surgery upfront, or sometimes we might be able to give them some chemo and radiation to help control the cancer, get it to a smaller size,
Before
and
operating.
then operate the surgery.
Let's, because you're a surgeon, I think the best thing to do is really dive into the surgical options that we have. And if I'm not mistaken, you have a case series on the procedure called the Whipples.
Yeah.
So talk to us about
Right.
the surgery.
So a Whipple operation, it's for tumors at the head of the pancreas. So you have a tumor this size, but it's located at the head of the pancreas, and has to be locally invading the pancreas only, and not any of the adjacent veins or arteries. Now, it's a very complex operation.
In what
It
sense?
involves removing the head of the pancreas and blood vessels.
Yep.
It involves removing this part of the small intestine, which is called the duodenum,
Yep.
and the gallbladder, and the bile duct,
Right.
and part of his stomach. Now,
So this is
after
complicated, right?
it's a very complicated
and it
operation.
is very technical as well.
Very technical.
So there's a lot of risks associated with it.
Yes.
Now, one of the questions I want to ask is, can a person live without all these structures comfortably?
Oh, yes, for sure. You can actually live without your pancreas.
But you're also taking the gallbladder past the duodenum in the stomach.
Yeah,
You're
because the
taking
blood
gallbladder.
supply is shared, and the risk of tumor spread tumor spread to the adjacent structure is high. You want to remove that. So when you remove it, you want to remove the tumor and make sure and get what you call negative margins for
Right.
cancers.
Yeah.
Then you have to do a reconstruction, and there are 3 different reconstructions you have to do. You have to join back the bile duct to the small intestine,
Yeah.
the stomach to the small intestine, and the pancreas to the small intestine. And we have achieved that using minimal invasive surgery in
That's
the
the
Caribbean.
laparoscopic surgery you're
That's a
talking about.
laparoscopic surgery.
So tell us a little bit more about that.
All right. So we performed the laparoscopic Whipples approximately 2017. It has been published in 2020. And we have presented this at different levels at the Caribbean College of Surgeons. And
And that's the first in the Caribbean or
And that-
first worldwide?
that was the first in the Caribbean.
Okay.
We then went on to do approximately 8 more laparoscopic Whipples. And that's probably the largest series in the Caribbean.
These particular patients, how long do these operations take? Because it's not something simple.
Yeah.
It's not just resecting different areas, but you also need to join back all these areas too. So how long does a patient typically spend under the anesthetic for this operation?
Right. So for what we'll call a simple Whipples, which wants for a better word, but it's probably approximately 6 hours.
Okay.
They can go on for 12 hours. Depends on how complex they are. The first laparoscopic Whipples we did in the Caribbean actually took us just approximately 8 hours,
Okay.
which is pretty
It's a long surgery.
long operation. Yes.
So let's just take a quick break, and when we come back, we'll talk about complications and anything new that there may be with the treatment of cancer.
Sure.
Don't go anywhere. When we come back from the break, we'll be talking to you about treatments and complications, as well as new advancements in surgery.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high-quality, convenient, and fast scans. With $800 off all MRI scans, we guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back. We're talking about pancreatic cancer today, and before the break, we were talking about treatments. Now we're going to dive into the possible complications of surgery. So, Yardish, let's go into complications that you've seen before, common ones. What can people expect?
Right. So a Whipple's procedure, as I said before, it's a very, very complex procedure. Complications has been pretty high in the past.
Okay.
However, in modern times, with the advent of different treatment regimes and proper preoperative assessment, and actually having trained personnel who are skilled in performing this procedure, the complication rate has been decreased. I mean, common complication rate, things as simple as infections, blood loss. But however, specific for the pancreas, the Achilles heel of a Whipple's procedure is actually the joining from the pancreas to the small intestine. It's called the pancreatic jejunostomy.
Right.
And leakage from that carries a very high mortality.
Yes, because of all the secretions from the pancreas.
Yeah.
And if it comes out of that joint, it can cause severe irritation and effects to
it's
the
proteins.
Yeah.
The proteases, they will destroy the cell, destroy the arteries, the veins. You can have bleeding. You can have a blown out of the anastomosis, and this can be lethal.
Yeah. So can you touch on what the complication rate looks like generally?
Well, in the past, complication has been high. I mean, you look at back in the 1930s, you're looking at greater than 50% complication rate. However, complications have come down to less than 5%,
Which is quite great.
which is very, very good.
The advent, or I should say the move from traditional open surgery to laparoscopic surgery, has that had an effect on reducing complication rates and therefore mortality?
Well, the answer to that is the surgeon has to be skilled at what he does. So if he is skilled at the open procedure, his complication rate will be low for an open procedure. If he's skilled at the laparoscopic procedure, then so complication rate will be less if you're skilled at the type of operation, the modality that you use. So with experience, I will say, not the operation type, not open versus laparoscopic.
Okay.
But with the experience in doing a large number of cases, it decreases the complication rate.
Okay. So let's talk about the more juicy thing. So what's new? What are the advancements? Because I know you touched on it, and there is something that came out this year, I think.
So just recently in February, on February 12th actually, published in the scientific journal, there's a new blood test on the horizon. One of the problems with pancreatic cancer, there's no screening.
Right.
So there's no, for instance, if you screen for colon cancer, you could do a colonoscopy. If you screen for breast cancer, you do a mammogram.
Right.
However, there isn't a test to do. So a CA19-9 is not a screening test. That's a tumor marker you use if you have pancreatic cancer.
Correct, yeah.
What we use is more invasive tests such as endoscopic ultrasounds and MRIs. Now, those are both expensive and invasive.
Yes.
So it's not commonly done. Now, just recently, as you said, in February 12th, at the OHSU in Portland, Oregon, this is a lab test that they did, and it's called the Pacman test. Now, it is simple and it's cheap. It takes a small amount of blood. Now, what it does, it detects certain types of protein called proteases within the blood that are present in patients with pancreatic cancer. Now, it has a 95% accuracy and an 85% early detection rate. Now, this is still at lab stage.
Right.
And they're going to start clinical trials and hopefully keep our fingers crossed, because if this test, Pac-Man, as we all know it as a video game, will become probably one of early detection tests for pancreatic cancer.
And that would be amazing. That would be a great advancement. So then we have a screening tool.
Exactly, for the masses.
Yeah. What is one sign or one thing that you've seen that is highly associated with pancreatic cancer?
Well, patients who were not diabetic and suddenly becomes diabetic, that's one of the diseases that, if detected, you should investigate for pancreatic cancer, especially in an adult population.
And I think that's important because a lot of clinicians wouldn't routinely look
No.
for pancreatic cancer
Yeah.
in a sudden onset diabetic.
I mean, there are other risk factors for pancreatic cancer.
Of course, such as chronic pancreatitis, gallstones, alcohol consumption,
Smoking.
smoking. I was just about to say smoking.
So smoking there's a 30% association between smokers and pancreatic cancer.
Okay.
Also, a strong family history of pancreatic cancer.
So what would be your take home for persons on prevention and preventing pancreatic cancer?
Well, there are certain fixed things that we can't help. So as we get older, right?
Of course. But things like
being
smoking
being a
cessation.
meal. But however, things that we can fix is smoking. But we stop smoking, stop drinking alcohol, and also obesity and overweight has been associated
Right,
with
yeah.
cancer. So those are the three things really that we can adjust in our daily life. And as I said, smoking, alcohol, eating healthy, diet and exercise. It actually seems to be the cure for most of our cancers, not only
Yeah,
pancreatic.
not just pancreatic cancer. We were touching on that last month with kidney cancer as well. So
It prevents. Those are risk factors for a lot of other cancers.
sure. Okay. So that's all we really have time for today. But thank you very much for coming. And hopefully we might see you again sometime in the future.
Thank you very much.
Thank you for watching today. We hope you enjoyed the episode. If you were unable to catch the whole thing, feel free to catch up on social media. So that's YouTube, Facebook, and Instagram. If not, just send us a message and we'll send you the link. Thank you again. We'll see you next time.